Our next speaker is going to be introducing the concept or explaining us a little bit more about the kidney involvement in Erdheim-Chester disease. As you know, the kidney always had a key or frontline role in trying to understand this condition and diagnosing it, as it was part of the triad, the kidney involvement with the hairy kidney, pituitary involvement with diabetes insipidus, and bone disease. So Dr. Augusto Vaglio from Meyer University Hospital in Florence, Italy, also a lead physician for the ECD Care Center at that location and an active member of the Medical Advisory Board, is going to give you an overview about the clinical spectrum of kidney and urological involvement, including some treatments and way and how we can live with those issues. Thank you.
Thanks very much, Juby, and thanks to all of you for coming and for listening. I'm a nephrologist, and this is quite unusual, I think, for the community, but actually I think a nephrologist is useful in general, but also in patients with ECD. And so my talk will focus on the kidney issues in patients with ECD. So first of all, I would like to start with some anatomy, so how the normal kidneys are, where they are. They're here, as you can see. This is a picture from a textbook that almost all medical students around the world use. So you can see the two kidneys which receive the blood from the aorta through the renal arteries. The blood goes to the kidney, it goes back through the renal veins, and it goes into this big vein, which is the inferior vena cava. The kidneys produce urine, which flows through the ureters, which are these conducts, these sort of tubes that go into the bladder. So the urine flow is kidney, ureter, and bladder. And you can see that there is this kind of membrane which wraps some organs, and this is the peritoneum. So the peritoneum kind of wraps the intestinal loops, and what is behind the retroperitoneum is the space that we call retroperitoneum. And as you have already seen in many previous presentations, the retroperitoneum is a site of infiltration, it is a frequent site of infiltration for ECD. We can also see where the retroperitoneum is through this image. This image shows a cut of the abdomen, which is what we call an axial view, an axial cut, meaning this is kind of a horizontal cut. Here you can see the spine, the two kidneys, the paravertebral muscles, and this is the peritoneal membrane. So this space is the retroperitoneum, and the anterior space is the peritoneal cavity where the intestinal loops are. If you take a CT scan, so a computed tomography, you can see that the retroperitoneum is this space. And if you don't use contrast medium, you can see something, but it's not enough in most instances. And so you have to, when you do your CT scan, you should use contrast medium because this helps visualize the normal structure or the structure of the kidneys and the whole abdomen. So this is a normal retroperitoneum where you can see how nice these kidneys are. You can see their shape is normal. You can see that the borders are normal. There's no infiltration. Whereas if you look at a patient with ECD that has retroperitoneal disease and perirenal involvement, you can clearly see that there is an infiltration around these kidneys. Look at the normal kidney, look at this kidney. And you can also see that there is another important issue, that the structure of the kidney and the morphology and the texture, I would say, of the kidney is completely different. So what happens is that the disease has what we call a tropism, so the tendency to invade a specific site, and this site is just the perirenal area. And normally the infiltration is all around the kidney and extends to the proximal part of the ureter, so of the tube that lets the urine flow from the kidney to the bladder. This happens, as I said, in about 50 to 70% of the cases. This is a mistake, sorry, it was from a previous slide. Actually, it was from a slide of maybe 9 years ago. And our cohort was 28 patients, and now we have about 80 cases, so this has grown a lot. And this is probably not just because we are better recognizing, but because there's more awareness in general. Perirenal disease has another potential disadvantage. If the perirenal disease extends to the proximal part of the ureter, then it can obstruct the ureter. So there is an obstacle for the urine to flow, and normally this leads to dilation of the kidney, and this is what we call hydronephrosis, and I think you've heard it before. The problem is that if you have all of this tissue around the kidney, this also probably limits the ability of the kidney to dilate. And this is an additional reason, an additional cause of injury to the kidney itself. But there is a little advantage for a patient with ECD when having retroperitoneal perirenal disease, is that this is a good site for a biopsy. It's a good site because we can do a percutaneous biopsy, meaning that we punch a needle in the back and we reach this tissue through the skin under a computed tomography guide, and we can get a good piece of tissue where you can see here, which includes, it might include a marginal area of kidney tissue, kidney parenchyma, but mainly it gets a perirenal disease, so the heart of what is the pathologic infiltration. And this is very important because in some patients we do not have easy sites to where we can make a biopsy. We know that a bone biopsy can be, hard to perform. It can also yield not very good material. We can't do heart biopsies. We seldom do brain biopsies. So this is a very good site for a biopsy. And actually some patients might have a very limited disease, meaning that they only have bone disease and perirenal infiltration. So in that case, the perirenal tissue is the ideal site for a biopsy. When we stage, so we work up patients with ECD that have retroperitoneal disease, we usually use ultrasound, computed tomography, MRI, so magnetic resonance imaging, and PET-CT. There are advantages and disadvantages of all of these imaging techniques. Ultrasound is very useful. It's cheap. It doesn't carry any risk. It's non-radiating. But it allows the visualization of the hydronephrosis, of renal artery stenosis. It's a good screening imaging technique, but it's not as precise, as fine as CT or MRI can be. CT and MRI provide an optimal visualization of all the renal and ureteral complications of ECD. They are standardized, whereas sonography largely depends on the ability of the operator. Computed tomography needs, as I said, requires, in most cases, the use of contrast medium, which can theoretically be a problem for kidney that have an insufficiency or a functional insufficiency. And it can be contraindicated for patients that have allergy to this kind of medium. Whereas MRI is usually contraindicated when you have a very severe, very advanced chronic kidney disease. And it can also be contraindicated when you have allergy to metals, when you bear a pacemaker or a metal prosthesis. Finally, we often use PET-CT, and PET-CT does not allow a visualization of the morphology of the disease, so it doesn't really tell us how thick the tissue is, where it infiltrates, which parts of the ureters of the kidneys are involved, but it provides very important information regarding the metabolic activity of this tissue, which means that if the tissue is active, so if the disease is ongoing at that site, this can be amenable to treatment. The problem is that in most patients that develop renal and ureteral involvement, this manifestation, as for many other ECD manifestations, is quite insidious, is quite silent. It's not symptomatic, and we can't really do anything to detect it at an earlier stage if this is the first symptom of ECD. So the disease involves the perirenal space, but also, as I said, often the proximal part of the ureter. What can we do if this is obstructed and we need to relieve obstruction? We can put stents. Stents are tubes which we call double J because they have a J here and a J here that anchor the stent in the ureteral system. These stents are normally used, for instance, when you have a stone, you have a colic pain. If you have a stone, then you use a stent in a way to bypass the stone. So for the urine to flow, this helps the urine flow. Here, ECD has this area of interest, of infiltration, so the stricture by ECD is almost here, so we need to relieve that kind of obstruction. We can put a stent. And normally this is good for patients because this is not a very invasive technique. It's usually done through the bladder, so via cystoscopy. And there are also some types of stents which are particularly effective in relieving the obstruction. These are called tumor stents. They have reinforced segments to overcome the stricture. The problem is that the stent is a foreign body, so as a foreign body, it facilitates infections. Sometimes it's irritating, so you can have blood in the urine when you have a stent. Sometimes it causes pain. The stent causes pain itself. So it's not easy, and normally you have to replace them every 6 months, and these tumor stents probably every year, but nevertheless, it's nothing permanent. Another way to relieve the obstruction is to drain the kidney from the skin. So again, a percutaneous procedure, which is called nephrostomy, and this is really bad for the patient quality of life. Because you have a tube that goes out, you have a bag to collect urine, your whole life is impaired. I would say when you have to take a shower, you're going to go running, or in summer or whatever. This is usually very bad for quality of life, and also because it favors infections as well. But these are only temporary procedures and temporary measures to relieve obstruction. The core of the approach to the patient with ECD that has ureteral involvement is to start medical therapy as soon as possible, because this is the only way we have to induce a regression of the tissue and therefore to reduce the degree of obstruction of the ureter. So this is to say, if you just put a stent, you can relieve the kidney, that's okay, but the cause of the stricture remains. If you put a nephrostomy tube, that's the same story. But if you do these procedures and you start medical therapy right away, then you're likely to have a relief of obstruction, which is more permanent over time. What are the consequences of all of these types of renal and urethral problems in ECD patients? The consequence is renal failure, which is something that means that functionally the kidney doesn't work anymore. Or this is usually a slowly progressive process. It can also be acute in some patients, but it's usually a slowly progressive process, and this is what we call chronic kidney disease. And when the chronic kidney disease is advanced, we usually refer to a staging system from 1 to 5. So when you have chronic kidney disease stage 5, this means that you need a replacement therapy. A replacement therapy is either dialysis or transplantation. There is also an additional problem which should not be overlooked, and this is renal artery stenosis. This means that the tissue compresses not only the kidneys and the proximal ureters, but also the renal arteries. And this is an additional cause of kidney injury, but it has another consequence, which is a severe form of hypertension. So if you compress the renal artery, you can get what we call renal vascular hypertension, because it's a type of hypertension which derives from the involvement of the renal artery. So this should be suspected this is present in about 1/4 of the patients. It can be suspected when on imaging there is involvement of the renal hilum. We can do something. We can put a stent in this case as well. But before the stent, we need to do a procedure which is called angioplasty, which means that we go in the artery with a catheter, and a balloon relieves the obstruction, and then you put a stent to keep it patent. So last 2 minutes for a little bit of science that we did with respect to renal involvement in ECD patients. This was a study that we published a couple of years ago. This study was done, Italy, France, and in this study we collected 195 patients with ECD and studied their renal function over time. And we followed them for a median of about 4 years. So what are my figures and my projections are out of 4 years of diagnosis. And you can see that there was a substantial proportion of deaths, about 20% of the patients, and an additional 5% of them developed end-stage kidney disease. And this was due to the combination of all of the urethral obstruction, renal artery stenosis, and other factors as well. But the thing is that we should not forget that patients with ECD often have comorbidities like obesity, smoking, dyslipidemia, hypertension, diabetes. And actually what we found in our work was that these comorbidities matter a lot in the evolution of kidney disease over time. So these are the main predictors of outcome, as you can see in this table, where the items, the comorbidities listed in the box are the ones that predicted the best renal disease. We can also do kidney transplantation. This is a long procedure. I'm not going to go through this in detail, but you have to know that the kidney you transplant is placed in an extra retroperitoneal position, so apparently should not be attacked by the disease. And the transplanted ureter is connected to the bladder, and the transplanted renal artery and renal vein are connected to the external iliac artery and vein. This is something that has been performed very rarely in ECD, and this study, which is currently ongoing, but we have closed the data collection because these are the only 7 cases of patients with ECD that have been transplanted, and I have to thank some people in the room in particular because they provided data from their relatives. And this was not an experiment, so we just had a look at the outcome of patients with ECD that developed end-stage kidney disease and received the transplant. And actually what I have to tell you is that the outcomes are so-so. 4 patients died, but I think it was not because of the transplant itself. I mean, they died because ECD is, in some cases, is a very severe disease. They had comorbidities, so they were probably the disease was not well controlled. We really don't know. we still think that kidney transplantation is an option for patients with ECD, but we should look at these patients very carefully, and transplantation should be done in centers where there is also ECD expertise, not only expertise in kidney transplant. So kidney transplant doctors and ECD doctors need to talk to each other because this is a very difficult management. And there is also the suspicion that ECD may recur on the transplanted kidney. You can see that the transplanted kidney is in a different position as compared to the native kidneys. We have we're not certain about this, but in some cases we observe that there is again an infiltration around the transplanted kidney. So this should be monitored really carefully. And this was my last slide, but actually the last is the one to thank some people. In particular, these are the people that really contributed to the kidney studies, not the ECD studies overall. The first is Francesco, who was here just a few minutes ago, who have been working with for the last 6 years, and he really boosted research on ECD in our center. The second is another Francesco, who is a fellow of mine since I think maybe 8 or 9 years now. He's a brilliant physician, and we hope he can contribute more and more. The third is another Francesco who is not here, but he will be here in a few hours. He's a young pediatrician and very funny and gives a lot of spirit to the group. I believe that there will be other Francescos coming. Julia, Anna Maria, and Elena are also from our hospital, and this work could not be possible without the French team, led by the King Julien Roche, led by his fellows, and by a brilliant pathologist whose name is Jean-François Emile. Some of you know. He's a referral person for all of us. And also thank to Eli, who's just arrived, I think, for the many exchanges that we had, and Corrado from Milan. And really my thanks go to the ECD Global Alliance. They contribute not only as a general support, but also sometimes with specific projects, like the one on kidney transplantation. I was able to get data from these 7 patients through the network. So without the network, this would not be possible. Thanks very much.